Hello, Dr. Dave Hindmarsh, GP Templates. In this video, we're going to talk about Quality Improvement Project, and I was really excited to be able to sit down with our local Quality Improvement Project winner. Turns out she's one of our registrars, and this project wasn't done in our practice, but it was interesting to have a chat to her. And thinking about previous video of the unfair advantage, you can really see that she's leaned on three areas. One, insight and intelligence. So she chose a condition that she had particular knowledge in and was able to sort of really drive her forward and improve the care. Two, location. Now, it just so happens that she used her QIP for not only in primary care and also in secondary care to really sort of try and bridge those barriers that unfortunately can naturally be there. And then lastly, education and expertise. So clearly she's a doctor, so she's got that insight into what is going on, but actually she's got the expertise of knowing what happens in primary care and knowing what will be able to work in terms of nudging things forward. So let's cut over to the interview. Enough to be joined by Dr. Cottle, who is one of our fantastic registrars who I've strong-armed into coming onto the channel. So Thank you very much for joining us. I invited her on because I've done video about quality improvement projects, and this one won the Durham and Tees Valley Quality Improvement Project of the Year, and so she very kindly agreed to have a chat about it. So do you want to tell me about your quality improvement, what you did?
So it started off as just an audit at first, and it was in Yarm medical practice, and I'd just come back off maternity leave myself and had gestational diabetes myself, so I thought, well, I kind of read up on it at that while being off and knew what the follow-up procedure was going to be. So I thought, oh, there'll be a good audit when I go back to work after mat leave. So I thought, well, I'll do an audit. It's a quick one, simple. And then when I got the results, it was quite shocking how poorly women with GDM were followed up in primary care.
Okay.
So I did a bit more like reading about why that was, and I thought it used to be done in secondary care. So when women had GDM, they used to go back and go to clinics and have all these things tied up in secondary care historically, and then it moved to primary care. And I think that move from secondary care to primary care, there's just been a little bit lost in the transition of that. So I thought, what could we do to make that better? And I'm really interested in the interface between primary and secondary care, and I think that comes from, you know, I'm a registrar still, so I've still had hospital rotations. So when you're in hospital, you can hear the grumbles from secondary care, and then when you're in primary care, you hear the grumbles from primary care. And so I'm really interested in that, bridging that gap. So I thought, well, I'm going to liaise with the midwives at North Tees and find out what their thoughts are about GDM and follow up. And then that's why it then turned into a QIP about how we can put things in place to make sure that between the both of us, we are looking after these ladies with GDM. So that's what kind of...
So loads to really pick up. So your own... And I've seen this with a couple of registrars, that they use their own personal experience that they don't mind sharing, because I take it then you found it a lot easier to either motivate yourself, and you knew a lot of the information already.
Yeah.
So specifically on gestational diabetes. And then also what I think is great that needs to be highlighted is the fact that, you know, I'm a GP, I've been here now for 3 years, I'm still relatively new, but I can feel that I'm very siloed. So, you know, if it's not inside these four walls, it's very difficult for me to be aware of it, because registrars, you're in a quite unique position that you're moving about all the time. You've still got that, as you say, you're jumping from primary care, secondary care, often to different practices as well. That you can sort of sense those frustrations, and you're in quite a unique position to sort of adjust it. So what were the adjustments that you sort of put in?
So I felt like we were getting letters from secondary care saying, often it was a treatment recommendation of metformin or insulin or whatever people put on, and the admin team were coding for gestational diabetes, and then that was that.
Yeah.
And then you'd find that when women were coming in for the 6-week postnatal check, you would speak to, the documentation you could see was any problems in the pregnancy, no. And then it was almost like women were, well, that was the problem in the pregnancy, and now I'm better now, I've had the baby, I'm now allowed to eat and drink what I was eating and drinking before, and then it was just done and dusted to them. And without the GP kind of like having a look through the letters and, oh, you were coded as gestational diabetes, but that might have been made inactive since the delivery, and it was easy to miss. And my point was that in the 6-week check, there's tons to go through. It's really easy to miss these kind of diagnoses that happen during pregnancy. So another one was preeclampsia, gestational diabetes, hypertension of pregnancy. These things women can often be like, yeah, I'm fine. They've got other priorities now. You know, they've got a newborn, they're tired, they don't really care about the fact that they might need a blood test. The other thing was the midwives would tell them all this information at diagnosis. So you often get diagnosed about 28 weeks after the glucose tolerance test. And you go in for the kind of educational thing about what it means, what you have to do throughout the pregnancy. And they'll say, when you've had the baby, you'll have to have a blood test every year. You know, if we think about when you get that information to when you need the blood test, that's like 18 months down the line.
Yes,
no one can remember that. So I was thinking we need to have some sort of communication where we as GPs are being highlighted to invite these ladies in. So I'd liaised with the midwife and I explained about how coding works in GP land.
Okay.
That if you say to someone, please can you do X, Y and Z, the coders will pick this up and action it. You know, there's a clear instruction to do X, Y and Z. I said, if you say this lady has gestational diabetes, I said, you're relying on the knowledge of admin staff to think, right, well, that triggers this being recorded, recall set up for a year. You know, it requires knowledge. And although you can say, oh, we'll just educate, we have 10,000 conditions to deal with, they can't memorise it all. Yep. So I'd said to the midwives, I said, if you put anywhere on a letter, please do a HbA1c at 3 months and annually thereafter, I said it will be highlighted and actioned upon in GP. And I said, and that simple sentence that you could be auto-populated on any of your documentation towards, it'll get picked up. So they were like, well, that's a really easy fix, and then they agreed to do it.
Brilliant. And I know we haven't got the data like specifically hand, but you know, I saw the re-audit data that you presented. It was phenomenal, just through that simple action. And I think it highlights that certainly, because you could argue that a lot of these are SEAs because they're missed blood tests and whatnot, but then what I like is how you've not blamed the individuals and not blamed the individual GP doing the 6-week check. You've actually gone, right, it's a system failing. Who's at the top end of the system? Well, it's, you know, and again, I'm not blaming the midwives, but actually, is there something that could be laid out and knowing the system very black and white, saying we need to do blood at 3 months, blood annually thereafter, that it can't be misinterpreted, it can't be, you know, misconstrued. It is very obvious what needs to happen, and it should trigger someone to go, oh yeah, that makes sense. From that point.
It's like you say, it's not about a blame on an individual level. I was looking at, it's like, what's the easiest way that this could just be rectified? And I just thought, I know that all letters get reviewed, they all get coded, and I just thought that was an easy from top down. That's then done. Whether women can come in for the blood test is another matter.
I think that's a big problem. So you know, it'll be fine from that way. So,
but we can then say that we've done everything we can, and we then know to invite, and the recall's there, and it triggers behind the scenes for these things to be. I've just had mine done very recently, and Phoebe's 3, and I've only been in for 1 HbA1c, so I'm not the best.
I won't slap you on the wrist for that one. So
do as I say, not as I do. But yeah, it's all come back fine. So, but they were bugging me from my practice too.
Good. Yeah.
And I wonder, is that because of this letter that they've now started to code it from their end, where they hadn't done when I first had Phoebe?
Fantastic. So already showing like through lived experience your own sort of.
I'm getting pestered by my own GP to come in for this blood test where I didn't in the first year or so after delivery.
Gotcha.
So and
I think the benefit, one bit that I was really shocked by or could see the impact was because you'd gone to the source problem. So as with a lot of hospitals, they feed countless GP practices. So you unwittingly would have had a positive impact, right, without knowing about it, hopefully to all of these practices that they served. So your QIP not only has improved the care at that practice, but it's sort of, because you've gone to the root source problem, it's sort of spiraled out or sort of like Christmas treed out to all these other practices in the area to hopefully sort of have a huge positive impact from that way.
So I was so the other hospital in the area did not want to engage. They said, well, we clearly put on the discharge letter the diagnosis. We feel like it's up to GPs to take it from there. I think it'd be interesting as another audit to compare North Tees deliveries to the other hospital.
Shan't be named for because I haven't got that good a legal representation. So.
Whether there's a discrepancy between because I think if you could go back to them and say, well, actually, the North Tees patients are getting better follow-up.
I agree, sort of as a wider, almost looking at an ICB sort of level, whether actually are different pockets getting their regular blood tests in, and whether it can actually be because, of our patch of North Tees Hospital GPs, are they getting it because of this from that way? So in terms of your career and sort of what do you think it sort of taught you sort of from a registrar sort of pushing to qualified?
I think it's made me, I'm really interested in the interface between primary and secondary care, and I don't want to lose that. Like you say, when you become GP, you get within your four walls of the practice. I want to keep working with what we can do between the two, primary secondary care interface. I think I want to keep that aspect of my drive to improve things. And I know it's going to be harder, but it's just when you've been a registrar in the hospital, you hear the grumbles about GP, and you're there to say, well, actually, this is why we do this, and this is why this didn't happen. And then a lot of staff will go, oh, right, okay, I didn't realise that. And there's so much that both sides of the party don't realise what the other sides are doing.
Absolutely.
And I'd quite like to do, I don't know what it is, I haven't kind of figured out what that is, but I'd quite like to keep going with the primary secondary care interface and be some sort of liaison improvement between both.
So I hope you found that useful. In this video you can clearly see how Dr Cottle has had an absolutely superb quality improvement project, which not only impacted her local practice but actually the wider area, because if you imagine the hospital that's sending out these letters is impacting on all of these different GP practices. So absolutely well deserved. So when you're choosing your quality improvement, if you even want to take it to the next step, just think about the root cause of the problems and actually could you do something that would affect the wider region, i.e. is this something from the hospital that with just a little bit of nudging, bit of education, you can make a huge impact. I'll put up a link to the video for talking all about the QIP, which you might find useful. Very best of luck with the quality improvement projects. Just remember these are vital for your interviews as they put a really good ability to demonstrate your leadership abilities. Dr. Dave Hindmarsh, GP Templates, and good luck.